We have a very interesting lineup of speakers. I think newborn screening is not newborn screening, just screening, right? So newborns to prenatal and to the aftermath of screening. And I think it's, with all the genomic technology that's available nowadays and all the ways that we can identify diseases, then really our hope is to always be able to identify a condition even before the symptoms happen. Be it in the prenatal period, a newborn period, or even after that. So I think this session is really something that is eventually very transformative for healthcare. So we have a great lineup of speakers. I'm just going to skip to the very first speaker, Dr. Nancy Chien. She is the clinical professor at the Department of Pediatrics at National Taiwan University Hospital in Taipei, and attending physician at the Department of Medical Genetics and Pediatrics. I can't read the whole thing, it's going to be too long, but I just wanted to say that she really has made a lot of contributions to the field of inborn errors of metabolism and primary immunodeficiencies, and is the director of the Newborn Screening Center at National Taiwan University Hospital. And they are really a group that has been leading the charge in newborn screening. Nancy, please.
Thank you, Dr. Tan, and good afternoon, everyone. I'm Nancy Chien from Taipei, and my task today is to talking about newborn screening and also mention about some challenge we met before and how we solve those questions. And because of the diversity of the population here, I will briefly mention about the method we implied previously, and I want to use this introduction to bring more sounds here to facilitate more solutions in the future so that we can benefit to our newborn and also to our babies and populations. So for those you are not quite familiar with newborn screening, actually this is assistant. So for newborn screening, we want to use the integrated system to early diagnose the newborns with at risk of some kind of a disease. So for example, in Taiwan, I believe also in Singapore and Thailand, we all have a systemic newborn screening systems from sample collection to transport the samples to the centralized lab. And then we also need very important part is the follow-up and also the diagnosis. And here you can see the timeline for each step in Taiwan, I believe also in other countries. That, for example, we ask the baby to have the first sample collect at the age of 2 to 3 days. And we also request our lab to have the turnaround time, the report in 3 days. Because then we can have the report by 1 week of age for that babies, so that we can catch up those urgent situation, and then we can give them the proper treatment or intervention. And currently in Taiwan, and I can proudly say that almost 99%, 99.5% of newborns can be covered by our newborn screening system. And right now we have the capacity to screen for over 50 conditions for our newborns. The reason we can do that is because during those years, you can see here is the technical evolution that from the first beginning, we only tested for the traditional G6PD activity from the dry blood spot. Then we moved to more advanced technique, for example, the tandem mask technology, and then we also implant DNA screening to our newborn screening system. So during those years, we developed some new method to screen for new conditions, for example, spinal muscular atrophy or ADC deficiency. So I can give you a short summary is that previously we thought the key challenge to newborn screening, for example, was that previously we need one test for one conditions. But this can be solved now is that, for example, we can use tandem mass for multiplex to simultaneously measure amino acid and acylcarnitines so that with the technology we can move forward that using one test we can screen for several 20 or 30 conditions in one test. In addition, we also can do multiplex real-time PCR to simultaneously detect a baby with severe combined immunodeficiency and spinal muscular atrophy because those tests are using DNA as samples, so we can multiplex them together. So in that case, we can check both conditions together. The second solution we have is that previously when we're talking about those biochemical tests, we always talking about not specific marker, especially when we move forward to do the multiplex format that you can have a very good sensitivity or specificity for one conditions, but not for all conditions. Currently, we can use other methods to solve that problem or to improve that problem is that we can use a second-tier or third-tier test so that once we have a high suspicious samples, we can add on second-tier test. For example, you can use DNA test. You can use, for example, for MMA, methylmalonic acidemia, we use C3 acylcarnitine as the primary markers. Then we use MMA direct measurement as our second-tier test so that we can enhance the performance of the screening test. Another method to enhance the performance is that, for example, in our ADC deficiency, our first tier is using the tandem mass assay for amino acid and acylcarnitines profile. So we can measure the ratio of 3-OMD to phenylalanine. If that ratio is high, we can put that samples to our second tier method is that we use HPLC. It's more precise measurement for the 3-OMD markers so that we can have a high sensitivity for the ADC deficiencies baby. The third question, key question is how can we predict the phenotype? Because once we identify the baby at risk, we want to understand if the baby have an urgent need to be managed immediately, or probably we can wait for several days or several weeks or even several months. So besides genotype, we actually can use biomarkers. For example, when we do the Gaucher newborn screening, we use lyso-G01 biomarkers to separate the baby with neuropathic Gaucher disease to non-neurological Gaucher disease. So I think previously during this year, we have those experience, and so that we can use different strategies to improve our screening performance. And next section, I will use 3 cases to describe to you that even nowadays we have those methods. Sometimes we still have some challenge and some problems, and I hope you can also appreciate those questions and think about your own strategies to solve that. So the first case I want to show you is citrulline deficiency because that is quite common in this region. And previously we already proved that baby with citrulline deficiency, if they can be picked up by newborn screening. So you can see that if we can do the diagnosis age around half months or 1 month old, we can have a very quick jaundice-free conditions to those babies. In comparison to those babies with clinical identified jaundice or cholestasis, they need more times to be solved, or even one case actually died from liver failure. But you also understand that for citrulline deficiency, current acylcarnitine and amino acid detection is not good. So we actually previously proved that using only the citrulline levels, we can have quite high false positive as well as high false negatives. So that is a significant problem. So after a while, we actually add the second-tier hotspot scanning for those cases with a little bit high citrulline levels, and we prove that using this simple HRM scanning for the hotspot, we can highly increase the sensitivity for citrulline deficiency. Currently, we use 11 hotspots that can cover around 95% of mutations in this region. So our algorithm is that if the baby have a little bit high citrulline levels, we do the hotspot analysis, and if we identify 2 hotspots, we will call the baby back because he or she is highly suspected to have the condition. If the baby have only 1 mutations, in theory, this baby is not less likely to be patients, but please remember that we only screening for 11 hotspots. So in 5% of chance that the baby have another rare variant not be detected by our hotspot analysis. So for that case, we also ask the baby come back just to make sure that he doesn't have the second mutations. But this case, actually, we follow the algorithm, we check the hotspot, and we understand that the baby have only 1 mutations. And we thought that is less likely to be patient. However, the baby have very high citrulline level as shown here. So we ask the baby come back and see clinically how the baby was doing, and we understand that the baby have jaundice, also have abnormal liver function as shown here, and very high citrulline levels. So clinically, I suspect the baby still have citrulline deficiency. But what's happened to the previous screening results? Turned out that the baby have citrulline deficiency with 2 hotspots, and we missed 1 hotspot from our screening assay. Why was that happens is that because we use the DNA extracted from the dry blood spot. So you can see that DNA quality was good because you can see the first hotspot scanning is quite robust result. But for the second mutations, using the DNA from dry blood spots return to normal. But if we use the DNA extracted from the whole blood, the result was quite pretty. So by this case, I want to share with you is that probably sometimes using different sample may have different results, and I believe that most of you can understand that, but in the real case, we happen to have that situation, and that needs some clinical alert to understand that the baby is a patient. So please don't trust at all of your results. The second case I want to show you is that we use NGS as our second-tier test for fatty acid oxidation disorders. After we identify them have abnormal acylcarnitine profile. So this case also have abnormal acylcarnitine profile, And we do the NGS to sequence the gene for MCAD deficiency, and we found one likely pathogenic variant, and the others actually was classified as VUS because it's in a deep intro. But because the baby have a high C8 carnitine levels, as well as urine glycemas showing relatively high sulfuric acid, that is a marker for MCAD deficiency. So we classify the baby to be at risk of MCAD deficiency, and we instruct the parents that no fasting, but we also don't do the diet intervention. And 2 years later, he has a younger sister, and the sister also have a similar situations. And at the same time, the baby, the brothers have a secondary carnitine deficiency. So we do the reanalysis, just as Dr. Hades mentions, that doing the reanalysis, actually you can have a different result. So now we have the siblings data, so we can have PM3 and also the PP1 and also the PP4. So the variant now is classified as likely pathogenic. But I'm sure that someone cannot convinced by the data because those still are prediction. So we actually do the RNA-seq, and we demonstrate that the baby actually, the intron mutation actually create a new exons. So that's the reason they have the disease in the babies. So I think that case educate us that the variant interpretation sometimes may not be reliable. You need others' information to help. The third case is our X-linked adrenoleukodystrophy screening, and we identify the babies with high metabolites, but then we do the genotyping. However, we still cannot differentiate the baby with severe childhood onset phenotype from the less severe adult onset phenotype, only from the biochem and also the genotype. For example, this case, you can see that initially they have very high biomarkers, and even we show the genotype here, you cannot differentiate the baby with severe cerebral adrenoleukodystrophy babies from the other case with Addison disease only, or the others, they have no symptoms till now. So I think those challenges in our current newborn screening system may be solved by genomic sequence. Because we are talking about one test, multiple disease, and genome screening can surely achieve that goal. Not mention about the technical problems, but the second part is about non-specific markers. I think that we need to solve the problem of pathogenic, likely pathogenic interpretation, but in the future, probably that can be solved mostly. But I still want to emphasize the last part is about phenotype prediction. I think from what I can foresee now is that we still need biomarkers or other non-genetic confirmatory methods to confirm the affected status for the babies or the individuals. So this is just a favors of our own practice that we do the sensory neuron hearing loss for our newborns because of our ENT doctors' interesting. So we do the screening for 200 genes in 1,000 babies, and you can see that we call positive case in 6% of them. And we also demonstrate that almost 40% of them have some autosomal recessive variant carried. But for those positive case, the 6% positive case, you can see 1% have that mild GJB2 mutations, and that will need ENT doctors' long-term follow-up. And we also have around 1 to 2% of mitochondrial mutations, so they can have some preventive method to prevent the hearing loss. But I want to draw your attention is about the autosomal dominant part. Those account for 3%. And in that population, we need also the ENT doctors follow-up for their hearing loss, but we also need medical genetic or clinical genetic or even our eye doctors to follow up their eye condition, their collagen conditions, or something else. So I think that part will give us more challenge in the future because we need our physicians and also our genetic counselor to help, and probably we need to educate the parents to do the segregation in the family to understand the phenotype in that family to have a better interpretation for the variant. So I think from our journey, I want to share with you is that newborn screening should be a very important public health tool to help every babies and to give them the chance to early diagnosis and early intervention. But I think currently we still have a similar challenge is that we need to implant different screening technologies to help them improve the screening test performance. But we also need many collaborations and many efforts to accumulate data to understand, especially for the variant knowledge, so that we can make more robust variant interpretation to understand if they are affected or not. And I believe that in the near futures, we will use those genomic technology more frequently, but I am sure that we need more comprehensive and personalized counseling, and we also need ethical consideration and also the genetic counseling to help families. And that I need to thank my teams to have those results to share with you. Thank you.
Thank you very much, Nancy. We'll keep the questions to the end of the session, panel. Next, we're going to move further upstream, and we have Professor Martin Delatycki with us, who's a clinical geneticist at Victorian Clinical Genetics Service and co-director of the Bruce Lefroy Center at the Murdoch Children's Research Institute. And he has many clinical and research interests in genetic screening and neurogenetics. I think he's set up many screening programs, but one of the most notable of which is he's the co-principal investigator of a 20 million Australian government-funded study of genetic screening for reproductive risk entitled Mackenzie's Mission. And so his talk title, What Do We Know About Expanded Reproductive Carrier Screening? Martin, please.
Thank you. So it is fantastic to be here. And I'm told by Angie that I was the quickest one to accept the invitation because I love Singapore so much. And so I want to tell you two quick stories about how much I love Singapore. So in 2003, I was in Singapore and I bought my first ever flash drive and I went to Sim Lim Square and I was told if you could get it for less than $1 per megabyte, that is a bargain. And I paid $200 for this object. And I looked up today, for 8 Singapore dollars you can get 32 gigabytes. So it's 4,000 times cheaper now, but I was very happy with that. And then this is my second happy story, is this was my first ever Michelin star meal at the Hong Kong soya chicken, rice and noodle shop for $5. So there you go. That was another bargain. Now to the serious stuff. So I'm going to talk today about carrier screening through the ages. I'm going to talk about Mackenzie's mission, which you mentioned, and then say a few words about the state of play around the world and future possibilities. So there was a review in Nature Review Genetics a few years ago that said there's about 1,875 recessive and 200 X-linked disorders, and that there's probably more than 10,000 that will be discovered in the fullness of time, and that we carry an average of 2 lethal recessive mutations. And obviously the risk for pregnancies increases from outbred to inbred to consanguineous couples. And so genetic carrier screening began in the 70s because of the two biological happenstances that you could diagnose Tay-Sachs carriers by enzymology and hemoglobinopathy carriers by hematological tests. And then genes were discovered, and from the late 1980s we could do screening for things like cystic fibrosis, etc. And it began as ethnically based, but now is very much whole education. So in Australia, presumably, I was at school, so I don't know what was going on, but presumably they were doing hemoglobinopathy screening in the 70s. And then from the late 1990s, Tay-Sachs screening began, and Leslie Burnett in Sydney began, and then we followed in Melbourne doing high school screening. We introduced carrier screening for cystic fibrosis in 2005. We added SMA and Fragile X, and then various companies started offering bigger and bigger panels of expanded carrier screening. And last year, the government introduced free carrier screening for cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. They also introduced a Medicare rebate for Ashkenazi Jewish screening, but it was such a poor amount that no one's actually offering it, so that's not much use. And then expanded carrier screening has gone from testing mutation by mutation to using next generation sequencing, and we can now test more than 1,000 genes, and so we can offer screening for most autosomal and X-linked recessive genes. Of course, 2 of the 3 most common require a separate test at the moment. So SMA, which is mostly due to SMN1 deletions, and Fragile X, which is a trinucleotide repeat, but I think that whole genome sequencing will overcome this before too long. For Fragile X syndrome, this is a study from Alison Archibald that showed that the vast majority of the first 12,000 people who had the 3-disease screen who were Fragile X carriers had small pre-mutations, and they were all stable when passed on. And if you look at the ones who went on to have prenatal diagnosis, none of the small pre-mutations became full mutations, whereas the larger ones did. And so that brings into question whether we should be testing for AGG interruptions. So it turns out that if you have between 55 and 64 repeats with 1 or 2 interruptions, or between 65 and 69 with 2 interruptions, there's never been a report of such a repeat expanding to a full mutation. And so we now reflex when we get a repeat below 70 to do AGG interrupts, and if they have the requisite number of interrupts, we don't tell them they're at increased risk. We say you're not at increased risk, and that saved a huge amount of work. I think it's very important in reproductive carrier screening to only report likely pathogenic and pathogenic mutations, so accepting that you will miss carrier couples who have variants of uncertain significance. My opinion on reporting VUSs is that once it's happened, you can't put the genie back in the bottle. And the other thing I think that's worthy of discussion is to not report mild mutations. So, for example, 5T and R117H in CFTR, or the VAL281 LU in the CYP21A2. And several of my grey hairs are from counselling couples with mild mutations, because once you tell a couple they're at risk of something, it's very hard to say, don't worry about it. And so the other piece of information that I won't have time today to present in detail, but Lucinda Freeman did a study where she looked at couples who had received increased chance results from Invitae. And then we spent a lot of time looking at the exact mutations and classifying whether they were benign, mild, moderate, severe. And several couples, not only with mild conditions, changed reproductive plans, but people with benign mutations, in other words, weren't at risk of disease. So, for example, the biotinidase mutation that's been shown not to be cause morbidity were changing reproductive plans. And I think that, you know, it's okay if you've got people who are very well versed in genetics, but this can't be all done by geneticists, genetic counsellors. Obstetricians are doing this work, so I think we've got to be very careful about what mutations we report. In Australia, the College of Obstetricians and the HGSA, the Human Genetics Society, now say that all women and couples should be offered carrier screening for at least the 3 conditions, but ideally with an expanded panel. The American College of Medical Geneticists recommend 86 recessive and 16 X-linked genes. And they allow for reporting VUSs if consent is provided pre-test. Now, anyone in here who has counselled someone about a VUS that actually exists, I don't know about you, but every time I counsel about it, I think I'm doing a great job, and they walk out thinking they've got a mutation, for sure. There's nothing more or less. So getting pre-test consent that someone will understand what a VUS is and make an informed decision about something that's very unlikely to happen, I think is actually impossible and not very a good recommendation. So now on to Mackenzie's mission, the Australian Reproductive Genetic Carrier Screening Project, and there are a lot of people involved and a lot of institutions. Particular acknowledgement to TIFF, who herded all the cats that are on that screen and kept us reasonably in check for most of the time, and we thank you enormously for that. So why is it called Mackenzie's mission? It's called Mackenzie's mission because this couple, Rachel and Johnny Casella, had a daughter, Mackenzie, and she had spinal muscular atrophy in 2017, and she died 7 months later. And they had gone to a lot of effort to do everything to make sure they would have a healthy baby, but no one offered them carrier screening. And so they lobbied the government, and at the same time we were lobbying the government to fund reproductive carrier screening, and the then Health Minister, called Greg Hunt, said we need to do something about this, and so the project was funded and called Mackenzie's mission. And so we aim to screen around 9,000 couples for about 1,300 autosomal X-linked recessive genes pre or early in pregnancy. And we looked at psychosocial outcomes, implementation considerations, health economics, and with bioethics underscoring the whole program. We spent 6 months trawling through the genes and selected 1,300. The final number was reduced, some because of technical issues and some because it became apparent that the alleged phenotype was not caused by the genotype. And we only reported pathogenic, likely pathogenic, and we tried to only report if it was likely to have a significant childhood onset impact or if early intervention would improve prognosis. We did couple screening, so both members of the couple were tested and they got one of 2 results: increased chance if they were both carriers of the same recessive condition, or the woman's a carrier of an X-linked condition, and low chance if that wasn't the case. So we did not provide individual carrier results. We recruited over 1,000 healthcare professionals across all relevant professions: general practitioners, obstetricians, fertility specialists, midwives, genetic healthcare professionals. We tried to mirror how people access pre-pregnancy and pregnancy care, and we tried to make it relevant across all geography, ethnicity, socioeconomic classes, etc. Most enrolment was online, so people would go online, they would do their education online, compete a decision aid if they so desired, did the surveys, provided consent, and then they were sent mouth swabs to do the testing at home. So we made it COVID
nutrient deficiency. So Professor Nancy has alluded some of the technical issues with regards to this condition. So again, this is a long story, but you need to bear with me. You'll skip to the second paragraph. So the family pediatrician has asked about the carrier status for 2 siblings of a patient who are aged 6 and 13. So basically, they wanted to know whether they will be carriers, and if would they be, or if they were affected because they were not screened in the early years. Could they have the possibility of liver failure? Would they need to avoid certain food or medication, or do they need preparation for liver transplant, and so on and so forth, right? However, the testing laboratory disclosed the 13-year-old's carrier status because there were consent and assent for testing. However, did not disclose a 6-year-old, believing that the individual could provide this assent in the future. Now, this is a new idea about assent because in the past, a parental consent would be sufficient to do the job, right? But now, with a lot of research going on, assent seems to have been part of the system, and many of these genetic testing laboratory are also including this, have included assent as a requirement for children between the age of perhaps 8 to 15, for example. And this is a concept that's not quite familiar to many Asian working environment because we may have assent for research program, for example, research genetic testing, but not for diagnostic testing, right? But increasingly, we are seeing this being asked of us, particularly in private laboratories. So this is the question that's been asked, is that the first recommendation for genetic testing and screening is that the testing of children should be driven by the best interests of the child. So under this principle, it is important to get informed consent and assent for genetic testing. That was the argument, right? Informed consent is a well-established process and so on, but the assent is the affirmative agreement from a child who may not have the legal capacity to provide full consent. So these are some of these arguments, and you can read more about this in the latest journal article that we have written in the Medical Journal Malaysia, because increasingly we have been seeing this problem. Okay, case number 4 is about religious beliefs and ethics. So this is another cascade screening issue for a couple, and we sort of wrote this up so I can put up the pedigree. Otherwise, I don't put up pedigrees because you might recognize the family just in case, right? So this family has kindly consented for this case to be studied. It's a family who has, unfortunately, the first case to be diagnosed with congenital disorder glycosylation type 1A in Malaysia almost 20 years ago. So this is a very old family. The issue was following the death of that first child who has CDG. They actually had cascade screening done, and essentially the issue here is about termination of pregnancy in a couple here who has strong belief in their religion, and in this case, they were Muslims, right? So, and basically, you know, to overcome this problem, we need to consult the ustaz, the religious experts in this part of the world, and to get a better understanding. For example, religious tradition of medical ethics tend to differ from more secular approaches by stressing limitations on autonomous decision-making, by more positively valuing the experience of suffering, and by drawing on beliefs and values that go beyond empiric verification. What this means is that sometimes this so-called ethos of ethics might need to be adjusted, for want of a better word, in some of parts of the world where religious belief may have a bigger role or bigger say in decision-making in the lives of these families. We also had touched on quite a bit on DTC, direct-to-consumer genetic testing. I say this because in Malaysia, every other day in the clinic, I'm always been asked to see a family who has done, some of these renowned companies like Circle DNA. I'm sure some of you have heard. I mentioned their name here now because they had done quite a lot of these tests as recreational activity, for example, and sadly or well, I'm not sure what's the word for that. They had some results which they cannot resolve. They were told about it in the very thick report which they received. And many times these are young couples who are thinking of getting married or having children. That's why they sort of went for this test. And it's not expensive, it's not cheap either. But there are many issues, right? We have issues related to what can they do about genetic susceptibility, or even retail genetics or nutrigenomics, for example. Is there certain foods or things that they can eat to make their child or make themselves stronger, better, and everything else that you can think of, right? And it's a big industry, big business, right? Now, the issue is highlighted in red because the time is short. We have lack of problematic involvement of the healthcare providers. Basically, all this was done without the input from the healthcare providers, the adequacy of pre- and post-test counseling, the scientific validity and utility of the test, and many other issues that you can read about. And this is a big problem for us because, using this DTC, and we heard quite a lot of PRS today, and we have actually done systematic review on the clinical utility of PRS, and this is one of this report working alongside with G2MC, and we have actually concluded that there's still very little evidence of clinical validity of PRS at this moment, right? Clinical validity means what's the outcome of this testing that you do, okay? And this has been supported by various professional bodies as well. All right, so the ethical issues in this DTC genetic testing companies are listed there. And in Europe, for example, you heard today it's regulated, but not in the United States, and certainly not in Malaysia. All right, and I foresee that this will be a big ethical challenge for us as more and more couples and individuals go for DTC testing. And lastly, following many of these recent advances with gene therapy, for example, we find that many of our parents are very savvy. They go online, they will look up for new therapeutics. For example, in Duchenne muscular dystrophy, where ataluren has been used for nonsense variants. We have PARP inhibitors for BRCA mutations. But basically, the issue here is it's available but unaffordable, particularly in the context of LMICs. Okay, so this was a first case that we treated with gene therapy in Malaysia in 2020, right at the onset of the COVID pandemic. We all had to put on PPEs and everything else. But subsequently, many of these couples who came to us were desperate. Many of them did crowdfunding to raise the millions of dollars to pay for the medicine. And this is an ethical challenge that I find very hard to resolve because, the issue here is the treatment is available, the child is there, but it's not affordable. So many times we sat down and discussed this, and this is one of the ways that we try to resolve this is by putting up policy papers. And we work with some of these think tanks. For example, we call it, one of these is the Institute for Democracy and Economic Affairs, IDEAS, they call themselves, so with the universities. And we put up quite a number of papers examining the health economics, just like what Martin has shown, the health economics benefit of McKinsey mission. We want to show that, even though gene therapy is expensive, but if you use the appropriate health modeling, for example, Markov modeling, it might show beneficial benefits of spending on gene therapy, for example. And one of the things that we often stress on is the role of genetic counseling, or some of them call genomic counseling now. I think we can't stress enough of this. We actually, in this part of the world, have set up the Asia-Pacific Society of Human Genetics, and also the Professional Society for Genetic Counselors in Asia. We want to push this agenda of us that, clinicians may be too busy to handle genetic problems. They need clinical geneticists and the genetic counselors to work together, and there is a strong need for this in the community, and we have wrote up quite a number of papers on this. We are still in the midst, for example, in Malaysia. We just met the Ministry of Health officials trying to persuade them that there's a need to recognize genetic counselors as a career, because the poorer section of the community would not receive any genetic counseling, whereas the more affluent one might still be able to access this service. And lastly, this is some of the points to address some of the issues that we talk about. Perhaps we need a better standardization and consistency of ethical approaches. For example, we need evidence-based guidelines and policies, as I shown earlier, adopting the same policy across all laboratories. Basically, everybody should be on the same page, telling customers, in inverted commas, the clients, patients, rather than having arguments within each laboratories, for example. Secondly, the redistribution of work and responsibility resulting from the practice of genomic medicine. For example, it is common now to have mainstreaming, and of course this will result in problems where complex results interpretation are done by lay clinicians who are not trained in genomics, for example, and therefore there should be some kind of legislation that says that complex cases must be seen by genetically or genomically trained specialists. And of course, this is to help addressing the uncertainty in the interpretation and certainty of results. And basically, it's about changing the situation from a diagnostic odyssey, which we are all familiar with. Now, with this genomics, we are now getting clinical outcome odyssey, whereby you have the variant, but you don't know what's the final outcome, because many of these clinical history are unfolding even as we speak. And just to sort of put it nicely, in the UK, the Genetics Forum, there's a national case-based forum to discuss this. Perhaps in this part of the world, Australasia, East Asia, and Southeast Asia can get together with our friends from the global scene to discuss this kind of issue in common platforms like meetings like this, right? And this would help in a great way to resolve some of these problems. Basically, the ethics is leave no one behind. Familiar with this, I'm sure most of you are. It's been put up as a declaration by the United Nations. It's a part of the SDG goals. And many countries have national rare disease policies and framework. But it's time to put all this to work, because these ethical issues are not going to leave us, because patients will always be there waiting for us to help. All right, on that note, thank you very much.
Thank you very much, Prof Thong, for that talk. Can I invite the speakers to come sit with me in the sunset? We have time for some questions. The QR code is somewhere. Is there a QR code? Oh, yes, please. So please do scan the QR code and enter your questions into the pigeonhole, and we will see what we can address for this remainder of the time together. I think there are a couple of questions, and perhaps I'll start off with a question that was already put up during the talk itself. So they're going to flash it up. Okay, so anyway, I'm going to just read it out. So in the first talk, newborn screening for hearing loss was presented as desirable. But for reproductive carrier screening, this is more ethically, controversial. Is this difference warranted? So I think there's really some differences in the way we consider the conditions that are included for reproductive carrier screening versus newborn screening. Is there a difference?
That is a complex question at this time of day. I mean, I think that, you know, newborn screening is all about early intervention, improving outcome, and so I think that those conditions certainly, many of them we included in Mackenzie's mission, then, of course, there's many conditions you wouldn't do newborn screening for, but for which you do reproductive screening, that, you know, things like Tay-Sachs disease, for which there's no early intervention at the moment that makes a difference, so you don't need to do newborn screening, but reproductive screening is clearly indicated, but I might pass on to...
Yes, I think for newborn screening, when we pick up the gene list, we want severe disease, early onset, as well as intervention or preventive measurement is available. Especially Dr. NK mentioned about affordable. So I think probably we have less gene list compared to reproductive carrier screening.
Thank you very much. I hope that answered your question. If not, Owen, you can talk to them later on. There's a question as well for Prof M.K. Thong. Is genomic screening now more positively perceived now in Malaysia and other regions with similar religious beliefs? Yeah,
so I think there's a lot of interest in any kind of screening, actually. But in particularly, genomic screening has caught on as the way to go, particularly if they are thinking of starting a family. But the issue is related to the level of health literacy in the community, right? In many countries, the level of health literacy are not up to the mark to where they can appreciate the nuances and the challenges that are posed by all these complex technical terms, things that relates to options, for example. Many Asians basically believes in what the doctors tell them. So there's some paternalism involved here. So very often it's the healthcare providers that provide the information, but unfortunately, many of our healthcare providers are not trained in genomics. So very often you find, things like termination of pregnancy has been a very prickly issue because they would put personal beliefs into their sessions with the clients, for example, and that might pose some problems sometimes. Very often they are not aware of the options that are available or where to go, because many times this kind of information not accessible to a lot of these couples.
Thank you very much, MK. So there was a question about, for Martin, that did any of the increased risk couples that had children prior to screening, and how did the results affect them?
Yes, so that's a very good question, and the answer is yes. And for some, it was very difficult. So this was particularly for conditions where the onset was not always in the newborn period. So there's one couple I can picture very clearly in my mind where it was a gene for retinitis pigmentosa, and their daughter was 2 years old, and they elected to have her tested, and she had the two variants and had completely normal vision and normal examination, but what the future will hold is uncertain, and that was very difficult. So I think that's a very good question and important issue, that when you start a program, there will be children at risk discovered as a result of screening. I presume that once you've got the program really up and running, that'll be much less common, but to begin with, I think it's a big issue.
Thank you very much. Well, this question is quite popular now. It's with regards to assent. So when considering assent for children and genetic testing, who is then responsible for following up with them, with their results when they become adults? Yeah.
Yes, this is one of those hot topics that we have. Basically, it would be the service that provide the information at the outset. And many of these are research institutions. So at the end of the day, many of these researchers might have left the service, for example, or they might be transferred to another place. So it would still be in the health records, for example, and therefore the attending doctors in the service would probably need to follow them up long term. Like many of these kids that we have who we are seeing for many of these undiagnosed malformation, very often we transition them to the adult services, but very often they come back to us because most adults are not familiar with genetic and syndromes, and many of these children and their parents would prefer to come back, even to the pediatric wards, for example. So I would assume that the best interest of the child would be served by whoever had the best interest of them in their hearts.
Yeah, I think that's perfectly reasonable, but also I guess a lot of dangers to loss to follow up, right? I guess if not everyone can remember where they were as a child. Just a quick look at the questions. There are quite a scattered lot of questions, but perhaps I since I'm the moderator, I have a chance to ask the last questions. I'm just going to do that. I've been very intrigued by this Prof. Heidi's talk about the variants and the VUSs, and now that there is a move to classify VUSs into those that are likely and less likely, and with those that being at the highest tier, being likely VUSs, being possibly moved on to LP fairly easily. So I'm just wondering whether does that impact on the way we think about newborn screening or reproductive carrier screening? Yeah. Last question of the day.
Well, what I can say is that, Invitae used to send you emails out of the blue that suddenly the one we reported as VUS is now likely pathogenic and it's 3 years, and that's not a nice email to get. So I think it's tricky, and I think that telling couples once they've got children that we've changed our mind is not a simple thing. But certainly if they come back for further screening, they should be screened with the knowledge that is current then rather than previously. But we specifically requested that they don't send those emails more than a year after. And but it's you're damned if you do, you're damned if you don't.
Yeah, I think that is a very good question. But for me, I still stand on the position of a physician or a clinician. So I think that the baby or the patient itself is the most important. So whenever you have a VUS in the past, if you believe that is a etiology for that patient, probably you can request a reanalysis in a certain period. Or if you think about another etiology, I think go back to see the patient to understand the problem of that patient. I think that is the most important thing.
Thank you very much.